Thank you. Lovely to be here. Lovely for the invitation. I am by no means primarily an imaging researcher, so feel free to question or ask things that I may or may not have answers, but we will do our best. I'm actually hoping to get something out of this presentation today because we have an upcoming project where we are going to be having access to some imaging data in a population I'll be discussing. And I have some ideas about how we might go about analyzing that data set for the objective that I'll be discussing today. And I would love to have ideas from the crowd as well, in addition to the ones that I give you. So we're talking about the idea of developing new targets for TMS in psychosis risk. I'll talk a little bit about why that's interesting. And I'll also just kind of throw in some random stuff about imaging things I've done in the past just to fill out time. So I am trying to advance slides. And there we go. Okay. Yeah. Okay. So disclosures, I'm the founder and shareholder founder and one of the shareholders of Apert Health, which is the digital mental health company, which is completely irrelevant to this presentation. You don't have to worry about it. It doesn't influence it in any way, but I have to give disclosures. So we'll be talking a little bit about my previous work, some current planned studies using imaging, the current goal, one of the goals that my lab currently has, discussion of the data set with which I hope to achieve part of those goals, and then limitations of that data set and discussions about potential ideas for how to analyze it, which I think could be a lot of fun. So psychotic illnesses such as schizophrenia affect 1 to 3% of the population, depending on how you decide to count psychotic illness. Are you counting bipolar disorder with psychosis? Are you counting brief psychotic episodes, etc.? But it affects up to 3% of the population. And these are illnesses that start, as many of you will know, in late adolescence and early adulthood for the majority of people. It can be a little bit later, especially in women, but it often starts young. And there's a second peak for women after menopause as well. But for many in the majority of patients, it starts very young. And so that can cause long-term disability because it doesn't kill you, but it essentially causes significant disability for the rest of your life. It can also shorten your life by about 20 years. So it's a significant illness that causes a set of illnesses that cause a lot of morbidity and mortality and just suffering on a very large scale. To give you a sense, I mean, it's not a low prevalence disease, but it's also not a super high prevalence disease, and it's on the list of like the top 10 causes of disability in the world, which is sort of also on that list for things like back pain and depression, which are much more common. Right. So in terms of the impact it has because of how chronic it is and how long it lasts, psychotic illnesses are very much a major cause of disability in our world. They cause significant suffering. We have medications that help control the positive symptoms, which are the hallucinations and delusions and behavioral disorganization, but they don't really do a great job of treating cognitive and negative symptoms. And the negative symptoms are more the difficulties with wanting to go out and do stuff, emotional expression, depressive symptoms, things like that. And patients can have very low function even when adhering to meds. So the treatment of positive symptoms is a necessary but not sufficient part of the treatment. You have to treat them if the person is going to be functional, but once you've treated them, that doesn't necessarily mean the person will be functional, which is a hard problem that we currently face in clinical psychiatry. Work has been done to establish risk groups for psychosis development. And why is this? Well, in the same way that people have looked to prevent or delay the onset of Alzheimer's disease with things like the new autoimmune antibody-based treatments. The idea is if we can identify and therefore hopefully learn how to prevent or delay the onset of these group of illnesses, we might be able to improve outcomes. And in fact, we know that if you treat people very early in their first psychotic episode, they have better outcomes. So something about cutting the episode short tends to improve outcomes. We don't know if it's about, people lose less of their social network or because we're doing something that is neuropreservative. It's unclear exactly what the mechanism is, but we know it improves things. So even better if we could go even further back, identify people before they develop their first psychotic symptoms and treat those people in some way. Problem is we have no idea how to treat those people. We have an idea of how to identify people who are at risk of psychosis. We have clinics that are specifically for that purpose. We have clinical assessments that basically focus on whether or not there are kind of sub-threshold level positive symptoms available. available, present in the person. Sorry, I have a 3-month-old at home, so my brain doesn't work perfectly. That's also why I only got here 5 minutes before the thing started. If there's attenuated positive symptoms that are present, we assume the person may develop psychosis, and so we follow them, and we are there to treat them very quickly if psychotic symptoms start, and we do what we can to try and treat other, depression, anxiety, other issues that arise in order to hopefully do something about preventing or delaying psychosis onset. The problem is we don't actually know for a fact that that does prevent or delay psychosis onset for a number of reasons. Firstly, you'd have to follow people for 2, 3, 4, 5 years to know for sure. Secondly, only about 10 to 20%, and depends which study you look at, of the people that we consider to be at high risk for psychosis actually develop psychosis. You can have these attenuated psychotic symptoms for many reasons, including, having experienced trauma, which is a large, unfortunately, segment of the population. And so the people who are in those clinics aren't all necessarily those who will actually develop a psychotic illness long term, but it may have other trauma-related illnesses or just depression or anxiety. It doesn't mean they're not suffering and don't deserve care. They do, and in fact, their outcomes are generally worse than the general population, but they don't all develop, schizophrenia or bipolar disorder with psychosis. And so the specificity of that group is lacking, and therefore the ability to develop interventions for that group is something that is a challenge. It's currently a very active area of research with a lot of money put into it recently by the AMP Schizophrenia Consortium, which I'll be talking about later when I talk about ProNET, which is one of the 3 studies in that consortium. But it is still something where we can identify theoretically somebody who has a higher risk. We don't have a specific treatment available for them yet. So my program of research is to try and address this problem by using what we call computational phenotyping to characterize and stage early psychosis. So how we do this is we're trying to learn how to mix together computational models of behavioral tasks. So this is when you take a model like the hierarchical Gaussian filter, which is a Bayesian model of behavior, and you apply it to behavior that somebody has in a task. I'll give you an example of a task soon. And then you derive parameters at the individual person level, and you say, okay, this is now a marker of what we assume to be latent information processing processes in the brain that we can't access directly, but that we can generate parameters that represent those latent states. And then that gives us a better window into the actual information processing status of that participant at this particular moment in time. And if we can find markers that correlate with symptom or symptom progression, or that are predictive of outcome, then we have a new way of measuring these symptoms that is a bit more, that is getting at the latent information processing, and that isn't dealing with the problem of just looking at symptoms, which, like I said, a hallucination at a subthreshold level can be present in a patient who will develop schizophrenia and a patient who just has PTSD. And I say just, PTSD is terrible as well, but at least we can do better at getting people back to function than schizophrenia. So the idea is that we want to get at the latent information processing, the causes of the symptoms rather than the symptoms themselves only. We want to mix this with other techniques like digital phenotyping, so people's digital lives on their smartphones, ecological momentary assessments, clinical measures, with the idea that the more ways that we kind of come at measuring this problem, the more ways we can measure function and information processing, the better that we're going to be able to characterize and phenotype people who are at risk and who are truly going to develop psychosis versus those who will not. Once we develop clear trajectories of computational parameters, we can correlate these with things like imaging. We can actually look and say, okay, at this particular stage, this phenotype of person seems to have these findings on imaging, and this phenotype of person seems to have those findings on imaging, and perhaps this might explain the difference. And also these differences in imaging may give us clues as to different potential targets for intervention, either with drugs or with TMS, which I'll talk about a little bit later. That's what I just said. Perfect, good. And so this little, I'm not going to go through it here because it's long and we don't have time, but there's a paper we put out recently in Biological Psychiatry, which basically gives a model of how we use computational psychiatry and the kinds of parameters that you can generate from computational psychiatric models to integrate across different levels of biological explanation and to also look at the trajectory of psychosis onset. And that paper is kind of nice and succinct and kind of takes you through the literature. We have a follow-up paper coming out, well, that we're going to submit very soon that adds in emotional processing into that. We're almost done. I have to cut about 1,000 words and then it's ready. But it's coming out. It's going to be submitted soon. We'll put out the preprint shortly thereafter. But this model is basically giving you a sense of what sequence of steps we think might be present from an information processing standpoint in the lead up to psychosis onset, how we can measure that with the computational psychiatry techniques, and then what that might correlate to in terms of neurobiology as hypotheses that we can then test. And then if those hypotheses are right or we revise them and find the actual truth, we can then use that for treatment development. So that is the idea of what computational psychiatry does. It's about providing a language based on these models of latent information processing that help us integrate across different levels of explanation. And that's relevant because, for example, it's not necessarily immediately apparent if I have a finding in the cellular sort of molecular biology domain, how that directly is going to have an impact on how behavior and symptoms are going to be expressed. But when you derive parameters from a model of behavior, you then have a number that you can essentially correlate across different levels of explanation. For example, people have done this looking at imaging EEG, and there's no reason why you couldn't continue going lower and lower. It can be correlated with things like dopamine signaling, and that's been done as well. So these parameters kind of serve as a language that lets you get at latent information processing states and then correlate that across different levels of explanation. So some previous work I've done, this is some work I did here. This was for my master's thesis. It was a structural imaging study, and there is a connection to the future work that I'm going to be talking about here. It's not just to fill time. I was being facetious. But what we did was we took 322 subjects, healthy controls, disease controls, and patients with psychosis from databases for schizophrenia, frontotemporal dementia, and Alzheimer's. We wanted to have Parkinson's as well, but the Parkinson's scans were either too low quality or the people hadn't developed psychosis yet at the time when they were scanned, which was kind of sad. But we did what we could. The scan qualities were a little bit difficult. There were imbalanced groups. This was a master's thesis, so it wasn't, I didn't have access to the best and most latest data. So we used fairly liberal thresholds. And what we were interested in was the question of across illnesses where psychosis is present, and specifically for psychosis, we're talking about hallucinations and delusions. Across illnesses where hallucinations or delusions are present, is there anything in the brain that is consistent? With the idea being that if you strip away disease-specific elements, you'd be left with kind of psychosis-specific elements. And what we found was reduced subgenual anterior single cortex volume in psychosis compared to controls, and increased striatum and thalamus size in psychosis as well. Striatum and thalamus have long been implicated in psychosis, larger or smaller. There's conflicting evidence, and SGACC has also been found in schizophrenia as well, to be altered. So it was this is just structural, nothing functional here. But remember SGACC, because it's going to keep coming back over and over again, which is not surprising because it's involved in basically, well, not basically everything, but a lot of things in the brain, but it's something that keeps coming back over and over again. Then some time went by, and I went to Stanford for my fellowship, and I was looking at the research that was available, and I wanted to pick a project that would let me do a bit of work on TMS. And the reason for that was because TMS, for those of you who don't know, transcranial magnetic stimulation is a treatment that is used often in depression. It's been being used more and more for negative symptoms of psychosis as well, including here at the Douglas. A study was just finished, the Implement study. And it's a treatment that has a lot of interesting characteristics about it. It is theoretically targetable to different neural circuits because you can pick the part of the brain that you want to stimulate, and you know what other parts of the brain that part of the brain is associated with. Of course, perturbing brain networks is never as easy as saying, I want this to do this, and it does exactly what you tell it to. But it is, more targetable than, for example, a medication which goes to every receptor in the brain that can bind that medication. It has very few side effects. So this is a treatment that you go in, you get your TMS session. You might get tired, you might get a headache, but you're not going to get severe weight gain or long-term sexual side effects or anything like that. It is a very tolerable treatment compared to other treatments that we might give patients for psychosis, like antipsychotics, which have a lot of side effects. And what was exciting about that is we're thinking about treating people who are at risk for psychosis, which are kids. We're talking about 12 12-year-olds, 13-year-olds, 14-year-olds, 15-year-olds, maybe even younger. We would ideally not want to mass treat people with antipsychotics if we can, because that has side effects. Even the newer ones, not ideal to have somebody on drugs forever. And in any case, the kids won't take them. It's very difficult to get teenagers to take anything, and to think that they're going to take antipsychotics long-term without a very clear mandate to do so is probably not going to work and wouldn't be healthy for them anyway. And also, we don't know that it would prevent the psychosis onset anyway. It depends on what you believe the role of dopamine signaling is in psychosis onset. If you think it's a late or an early phenomenon, I think it's a late phenomenon, and so probably antipsychotics wouldn't be particularly helpful until you're close into the psychosis anyway. At which point you've potentially missed the boat on the big preventative potential components. But that's an opinion and controversial, so we can talk about it later. So because I'm very excited about TMS, I wanted to go where the hottest TMS research was, and at the time, and still I would say, that is at Stanford, where they have recently gotten FDA approval for an accelerated version of TMS, treatment for depression. Obviously, I want to do this in psychosis, not in depression, but there was a couple of interesting parallels. Number one, it is the treatment they're doing, which I'm going to describe in a minute, is it's accelerated, so you can do it much faster than current TMS protocols, which often take 3 to 6 weeks to complete. And we also had the opportunity, because the study included ratings of symptoms at each day. We could look at the symptoms that changed first and potentially get an idea of what mechanisms were at play. And so I looked at the very small number of people they had in their RCT, 23 people. The reason they're so small is because they actually had a positive effect of the midpoint analysis. They stopped the trial and gave everybody active, and then the FDA approved it. So that's why it's so few people. And we had data about symptoms available at baseline, daily during treatment, and then at 1, 2, and 4 weeks post-treatment. And we focused on the MADRS questionnaire, which is the Montgomery-Åsberg Depression Rating Scale. This is a questionnaire that's very commonly used in depression studies, has 10 questions, doesn't have every symptom you could possibly want, but it has many of them. And then we looked at outcome at response to 4 weeks post-treatment. We tried to see which symptoms changed first and whether those were correlated with imaging or could predict outcome. So first, a side note on what is Stanford neuromodulation therapy. So this is the new FDA-approved treatment. It's a form of neuronavigated rTMS, but it's not neuronavigated to an anatomical target. It's not just saying, okay, here's a scan, and we're going to neuronavigate to the specific coordinates of the DLPFC in this particular person. No, what it is it's a functional targeting. So they actually look at the functional resting state functional imaging. They look at the portion of the left dorsolateral prefrontal cortex, that is the most anti-correlated with the subgenital anterior cingulate cortex. Remember SJCC, I told you would come back. And the reason they do that is because there was previous evidence that showed, when you looked at other studies that treated people with rTMS, that the closer you got to that region of voxels that was the most anti-correlated with the SJCC, the better your treatment effect in depression was. With the idea that there's something about the LDL-PFC modulating or regulating the SGACC that is responsible for or is related to the treatment effect for depression. And it's an accelerated protocol, so it uses theta burst rTMS, which is a shorter protocol. You can get your session done in 3 to 9 minutes instead of 30 to 40 minutes. And they do it for over 5 days, 10 sessions per day. So 50 sessions in a week, which is a lot, because usually we do 3 to 6 weeks of a session to 2 sessions a day. This is everything crammed into 1 week, and actually even more than you get over the 3 to 6 week protocol. And there were previous open label and randomized control studies that demonstrated that it was effective against sham. And so what we found was that the earliest symptom to change was lassitude. Lassitude is that feeling you get when you're like sort of sick and it's a Sunday morning and there's stuff that you're supposed to do, but you don't really have to do it. And you're just kind of like in your bed and you're like, meh. It's the meh feeling. And this feeling is what some people with depression have all the time, and it's horrible. And what we found that was really interesting is it was the first symptom in the 5 days of treatment that changed. So day one, there were no differences between sham and active groups. Baseline, there were no differences between sham and active groups. Day two, we started seeing a difference between active and sham, and it was the lassitude symptom. Day three, same thing. Day four, same thing. And then day five, there were other differences as well, but the lassitude remained present. And so this was really interesting because it seemed to be the only symptom that had a rapid response to this treatment, okay? And this was exciting to me for a couple of different reasons. One of which was that lassitude is not the same thing as, but very similar conceptually to negative symptoms in schizophrenia. Because negative symptoms in schizophrenia tend to have people not being able to get up and go do stuff. If you bring them to a chocolate cake, they will eat the chocolate cake. But if you tell them there's a chocolate cake in the room nearby, they're going to say, meh, I don't really want to get up. That's a simplification of it, but that's the idea is that you're not losing the pleasure of the activity, but you're losing the anticipatory drive to go and participate. And so there is a conceptual, it's not exactly the same thing, similarity between lassitude and negative symptoms in schizophrenia, or at least some of the negative symptoms of schizophrenia. So lassitude score at treatment day 3 was predictive of response to treatment. This was also true at day 2. And then just to make it a bit more fun, we published this, I think 2 months ago. We looked at SGACC seated functional connectivity, pre-treatment and changes post-minus pre-treatment. And basically, we found a number of different changes that when you looked at functional connectivity between SGACC and other brain regions, each of them coded for the brain networks they're most often part of, we found that both pre-treatment and then post-treatment minus pre-treatment, there were a number of differences that were related to whether or not you had high or low lassitude at day 3. So we split people into whether or not they had high or low lassitude at day 3 of treatment. And then we looked at the differences between those people. And there were differences in connectivity to visual network, the dorsal attention network, and the DMN. And the DMN the default mode network is a brain network that's highly involved in both depression, but also seems to be one of the factors driving negative symptoms in schizophrenia. This is post-treatment minus pre-treatment. So the idea here, so pre-treatment was supposed to be predictors of treatment response. And then this is post-treatment minus pre-treatment, which is more markers of treatment response. So you're not predicting it because you're looking at the change, but you're seeing what changes if you're responding, what changes in the group that is more likely to respond to treatment. And again, we see here the change was more in connectivity of SGACC to the central executive network, which is again interesting if you're thinking about the idea of people having more capacity to motivate themselves to get up and move. So far, across these 2 studies, that were not planned together. I kind of did one and then did the other, and they kind of coalesced in a nice way. SGACC seems to be important, which is not that exciting considering it's an important region. It's a region which could be targeted with rTMS. This is more interesting. So obviously not directly, it's way too deep, but we can target it through the dorsolateral prefrontal cortex because we know that that region of the brain tends to regulate SGACC, and through SGACC, it seems to be its connections to other brain regions based on the networks I just showed you. It's a region which is part of and seems to be able to modify activity in the default mode network and to couple to other networks, such as the central executive network, which may be relevant to schizophrenia symptoms, such as negative symptoms. In fact, there was a recent paper that tried to look at imaging markers of essentially, if you have a target for negative symptom treatment in schizophrenia, what about that target predicts its effectiveness? There really wasn't any consistent findings except for maybe the changing the coupling between DMN and the central executive network, which is exciting because at least in the depression data, we see changes in coupling between DMN node, which is SGACC, and the central executive network post-minus pre-treatment. There's of course important region. There's also recent work that suggests the importance of other regions, such as hippocampus. Of course, here at the Douglas, there's a lot of work that's done on hippocampal and other regions being important in the symptoms of schizophrenia. So I'm not trying to say it's all SGACC. It's never just one brain region, ever. But I do think that it is a region that is targetable, and that therefore gives us an opportunity to make some some progress in treating different symptoms of schizophrenia. And what's also interesting is the Stanford study was looking at what's more correlative negative symptoms. And the first study was looking more at correlates of positive symptoms. So it may be relevant in multiple different symptom types as well. So we have a couple of planned studies currently that are going to be using the scanner. No data to show you yet because the scanning hasn't started, but it's coming. We have a study that is more computational in nature in terms of computational modeling of the behavioral task. So what we are doing here is we are taking the condition hallucinations task. So that is a task that was developed by my mentor, Al Powers at Yale, where basically you show people a, is there like a laser? No? Oh, but I can do this, right? Can you see the, no, you can't, okay, fine. You show people a visual stimulus, like a checkerboard, for example, and you flash that, and then you play a sound. In their original study, it was a tone. In our study, it's actually words. So you play a word and you show a visual stimulus, and you basically create a Pavlovian association between the two. And then eventually, if you play that enough times, as you play the visual stimulus, people will hear the sound even if it's not there. Okay, and you add varying levels of noise to the experiment in order to help induce that effect. And this is a very consistent task that's been studied in many different populations. I've looked at it in people who were in the general population who had more or less psychotic symptom proneness. It's been done in people who are who have active hallucinations versus those who do not. It's very specific to hallucinations, and it's you can generate parameters from that using the hierarchical Gaussian filter, HGF. And the parameter that's the most interesting is what's called new or prior weighting. So the more the person relies on their existing beliefs, the more they'll hallucinate in this task. And that seems to correlate. And that also changes over time. As people's symptoms change, their prior weighting changes as well. And so what we did is we decided to make this task much more complicated, and that was in the view of making it affectively valenced. And the reason we wanted to make it affectively valenced was because people at clinical high risk for psychosis tend to develop emotional symptoms prior to psychotic symptoms, okay? So they'll develop depression, they'll develop dysphoria before they develop the psychotic symptoms. And so to make sure that we can be sensitive in that population and differentiate from, the general population, we wanted to create a version of the task that was really affectively charged. And so what we did is that now instead of it being a tone, you actually have a positive, negative, or a neutral word. So love or hate or blarg. And then you will learn the association, and then you do a manipulation. In this case, the manipulation is the MIST task, which is a very stressful mental math task that was developed here, actually by Jens Prusner while he was here at the Douglas. And you either do really hard mental math and you're told basically that you're an idiot and that everything you do is bad, or you're told, oh, you did really well, that was fine, thank you very much, continue, right? And it's modeled after the Trier social stress task, which is a very, very stressful task, and has been shown previously to really kind of increase cortisol, actually. So beyond just making you subjectively stressed, it actually increases cortisol. And so the idea is we stress people, or we give them the control task, and then they do the rest of the condition hallucination task, and we look and see if we have more condition hallucinations after a stressful induction versus after a control induction. So far, that's what we see. And we're going to be taking this task to the scanner. We're almost on our pilot testing. We're going to be taking it to the scanner soon, where just because of the length of the task, we had to condense it for the scanner so that people don't, decide to walk out in the middle of the task. And we'll be looking at three conditions. We're going to be looking at when you have a negative manipulation, so the stressful MIST and a negative word like, hate, and then the stressful math. The positive manipulation with a positive word. Sorry, it was supposed to be, I think it was supposed to be positive manipulation and negative word, but I have to double check that. But an opposite manipulation to sort of see if, it's supposed to be positive manipulation, but negative word. So where you have a negative prior, but then we kind of try and rescue it with a positive manipulation, make people feel good about themselves. And then a neutral, like kind of baseline task where they'll hear a neutral word and then do a neutral typing task. Well, equivalent of the typing task that's adapted for the scanner, so that we can compare against. And so the idea is there that we want to see what the signatures are of this reinforcement of negative words by negative manipulations. So not done yet, but a little bit of preliminary data just to show you. So this is very exciting. You're the first people to see this outside my lab. Okay, so do not take pictures, do not share it. But I was very excited about this. This tracks across the 3 blocks of the task the prior weighting strength. So that computational parameter I told you about, that it correlates with increased condition hallucinations. The red line is the manipulation. And then what we can see here is at the top left there, the condition where, and orange is patients and blue is healthy controls. The condition where we have the negative word and the negative manipulation, we actually do see, in fact, an increase in the prior weighting after the negative manipulation and a big difference between patients and controls. We see a similar thing with when there's a positive word and a positive manipulation, but the difference is smaller, which is exactly what we hypothesized. So we assumed that when the word and the manipulation are concordant, you're going to have a boosting effect, but that the boosting effect will be bigger for the negative condition in patients specifically. And that's what we see here. So very preliminary, it's like the 12, 20-ish people, okay, controls and patients together, so don't get too excited, but precisely what we hypothesized, which I'm very excited about. So that's an example of a computational task and how to analyze it. We're going to be doing a clinical trial. I'm going to skip over this a little because I want to get to the part that's talking about the ProNET study. Where basically we're going to be doing rTMS for negative symptoms using the Stanford protocol. So this is kind of a easy pilot study where we're basically saying, okay, if we take the Stanford protocol and we apply it to negative symptoms of schizophrenia, do we have as good an effect as if we were to do the longer version of the protocol? And do we have can we produce the effect in that short amount of time in negative symptoms, which, you know, the brains of people with negative symptoms are going to be very different than the brains of people with depression, and they may be less responsive to treatment. It might take longer. So we have to establish that the accelerated protocol actually works. If it does, that would be very exciting because people with psychosis tend to not necessarily be as adherent to treatment as other patient populations. And so being able to do something in a week instead of 3 weeks or 6 weeks would be very helpful. And there was about a 20% dropout in the recent study at the Douglas that took about 3 weeks. And that's already a shortened version of the usual TMS protocol. So hopefully, if we were to shrink the treatment time more, we'll be able to get more people completing treatment. The reason that we're picking the LDL-PFC without further investigation is because that's already the treatment target for negative symptoms in psychosis. That's the existing accepted treatment target before we came on the scene. So what we're going to be looking at is, given that this is already the existing treatment target, if we specify that treatment target by targeting the region of LDL-PFC most anticorrelated with SGACC, does that actually correlate with improved outcomes? And does the strength of that baseline correlation matter in terms of outcome prediction? We're going to be comparing 3 different arms. Neuronavigation with active treatment, neuronavigation with sham treatment. So that's an active sham comparison with everything else being the same. And then a non-neuronavigated with active treatment other arm, with the idea being we want to really be sure that the fMRI is necessary, because clinically speaking, it is not going to happen for the majority of patients to get an fMRI. People are just going to take the accelerated protocol and use that without doing the targeting. So we wanted to just know, you know, from a sort of clinical realities perspective, is it really adding that much to do the targeting? I'm happy to do it because it gives us mechanistic information with the scans. Clinically speaking, it would be nice if we didn't actually have to do an fMRI in the future, but we'll see. And this is being done in collaboration with KMH. So thank you, Albin in the lab, and Dr. Paniapa. Now, the goal after all of this is to use the computational phenotyping to develop a staging model for psychosis. We really want to then correlate computational markers at each specific stage to define new neurostimulation targets. We want to confirm the effect of neurostimulation in target engagement experiments, then run clinical trials like we're going to get practice doing with this other study. This study is going to be done in schizophrenia because I was basically told that it is too early for anybody to fund a study in clinical high-risk patients, so we have to work our way up to it. But eventually we want to be doing these clinical trials in clinical high-risk patients. And then we want to be using our computational measures as markers of treatment response, because otherwise we have to wait 2 years to know if we did anything. Because like I said, it takes two to 5 years to actually convert to psychosis if you're clinical high risk. Now, the problem is we don't really have any computational phenotype cohorts available using the task that we care about. So grants are currently in progress. In the meantime, we could potentially get some ideas for initial targets that we might want to test in clinical high-risk patients. And that's where the ProNET Dataset comes in. So this is a data set that is slowly becoming available. There's already some data available, but more is coming online theoretically soon, like in the next couple of weeks or so, is what they keep saying. This study is a very big study of people at clinical high risk for psychosis, over 1,000 people, and they obtain clinical measures, cognitive measures, ecological momentary assessment, digital phenotyping, but not computational. So not the tasks I'm interested in, but they did get a lot of sort of smartphone-based stuff, which is useful. Natural language, which I know Albin is probably very excited about, and EEG and fMRI at months 0 and 2. So the EEG and fMRI data, unfortunately, is not fully longitudinal. This was a 2-year study per patient, but they only got the biological markers at months 0 and 2. So there are limitations to that, which we'll talk about. Because most people will not have converted to psychosis by that time. So if something happens in the brain that's important, 6 months before they develop psychosis, and they develop psychosis in 2 years, we will have missed that in this particular sample. This is the fMRI protocol, and it's resting state. So there's no tasks. So everything is resting state. So that's fine. You can get a lot of information out of resting state, but we have to be aware that we're only getting resting state information. But it will also have structural and diffusion scanning. And we will have clinical measures over the first 2 months at least, and we can correlate it also with the EEG. Limitations here are we have no clear staging method in psychosis risk. So the neurobiological data that's 2 months apart will likely be from a mixed population at the time of the scan. What I mean by that is not everybody who's recruited to the study at month 0 is the same. It's like saying if you're recruiting a cancer study, but you didn't screen people based on the stage of their cancer. So that at the beginning of the study, you will have a mix of people who are stage 1, stage 2, stage 3, stage 4 cancer. So in this study, because we don't even know how to stage CHRP, you will have people who are potentially at these different covert stages of CHRP that we don't really know what those are, right? But we will have trajectories of symptoms. So potentially what we might be able to do is look at people's trajectories over time, see if some people's trajectories look like truncated versions of other people's trajectories, and then create subgroups on the basis of that. And then go back to the beginning and cluster people based on those putative subgroups. We've done something similar to this. So this is work that was completed by rotating PhD student of mine, Yanan. The other graph I showed you was completed by my master's student, Tim, but I, for some reason, don't have a picture of his face, so I didn't put it up there, that's why. But kudos to Tim as well. So Yanan is in another lab now, but she did a rotation with me here at the Douglas, and we took the existing data at PEP. We looked at the symptoms, only symptom data at PEP, and we kind of looked forward through time over the 2 years that people were followed here. We clustered those symptoms based off of the positive and the negative symptoms and found 3 clusters of patients where essentially you have some patients who have a resolution of most of their symptoms. That's the green cluster. Other patients who have good improvement in their positive symptoms, but not so much the negative symptoms. That's the blue cluster. And then other patients who have kind of persistently high levels of both, which is the red cluster. And so I look at this, and sometimes I wonder, is the blue cluster completely different from the green cluster, or are they people that perhaps were caught a little bit later, and so there was more time for their negative symptoms to sort of become solidified? No way to know for sure, but it gives you a sense of how you might be able to start subtyping people in order to understand what subgroups people might be part of, and therefore to know what groups to look at for neurobiological differences. So how could we use this data from ProNET in order to develop new computationally, well, not computational in this case, but new mechanistically informed targets for rTMS in future trials, while we're waiting for the money to do the studies I actually want to do, which is the computational phenotyping of populations over time? Well, we could focus on the symptoms we know already correlate with our computational measures. So we could sort of do a proxy computational phenotyping. But again, once you start using symptoms, it becomes a bit difficult since symptoms could be related to multiple different things. And then see which symptoms change the most over the 0 to 2 months, and then correlate that with functional imaging changes over that time period. We could examine the connectivity at each time period under the assumption that these represent different stages. The challenge is we don't really have a ground truth of stage at this point, so we'd have to do some kind of subtyping of people around some, putative stage clustering to get a sense of which changes, what changes are meaningful given that we know that different people have different kinds of changes because they're probably at different stages in their trajectory at the same time. That was complicated. I'm sorry. I hope that came clear, but I'm happy to clarify what I mean after if this wasn't clear. We could focus on seed regions that we know we can actually target. So that would be kind of a cheap and easy way of doing it. Look at the regions that we know we can hit with our TMS and just see what correlates with those regions. And if those correlations are significantly correlated with symptom worsening or improvement over time. We could look at convergent validity through EEG data, or look at structure-function relationships since we have structural data as well. We could try and do sort of a case control kind of thing where we look at sort of normal networks and then try and see sort of what are the abnormal networks and then try and see if we could normalize those with TMS. We could look for patients who had worsened compared to those who remitted or who stayed stable in terms of their symptoms and examine differences in baseline connectivity or changes in connectivity that correlate with that worsening. And then ideally, we would find some hubs, some regional hubs that are very correlated with some marker that we're interested in order to identify a target that if we were to perturb that with TMS, we have some reasonable expectation to believe that we will actually have an improvement in symptoms over time. And that is the talk. So I'm happy, I'm going to leave this slide up because this is the interesting slide. I'm happy to take questions and we can talk about possible directions to take this particular analysis in ProNET. Thank you. Alvin, yes, go ahead. Yes.
I was starting, regional to those are different contexts, navigation area. How much improvement do you expect on it? Like, is it like a centimeter here or there, or is it like 5-10 centimeters?
So it's usually within, it's not centimeters. We're talking about tens of millimeters. Okay. This is why we have the arm that compares against the neuronav. Okay. Look, it was enough that targeting mattered in the Fox study, right? Where they were able to actually demonstrate that it was significantly relevant to treatment effect if you were close to that target or not. So even though we're talking about small differences, at the very least, standardizing it across patients should have some effect. The reality is, having watched this treatment happen, if someone breathes or coughs, and we don't readjust it, are we really getting the same level of effect? So do I believe, am I an evangelist of this functional-based targeting? No, but that's why I have the third arm of the study, right? Do I believe that it gives me a really, really good excuse to get scanning data that I can use for mechanistic investigation? Absolutely. Am I willing to be convinced? Also true. Okay, so I'm not pronouncing myself yet. But this is sort of an integral part of the protocol, and it gives me a really great excuse to get the scan. So, yes.
In my experience, if you go for group level fMRI versus individual differences, you are at the error rate of 2. So that is give a good rationale why to do the mechanistic. Sure, like I'm all for it to get fMRI, But the group level PFTFC anti-correlation with ACC, if you map it in HCP 1000 subjects and you look at the variability between the subjects, you have around the centimeter. This is 3 boxes. So if you get HCP with MRI, if you have normal MRI, 3 boxes, which probably be a factor. Yeah, my experience with that.
For sure, absolutely. And the other question that I don't think we've answered yet is, there is no guarantee that the target you get today, which is usually on the Friday, is the same as the target you would have gotten on the Monday, right? Because it's a functionally defined region; those can change. There's no anatomical requirement that it be exactly the same voxel, right?
I'm
Yeah.
not sure even people still talk about this, but fMRI as a stationary signal versus non-stationary signal is not. That's why they use dynamic connectivity.
Right. Exactly. So I completely agree with all of that. I'm not an evangelist. I'm doing this because this is the protocol that was done, so I want to keep things equivalent. And it gives me a wonderful excuse to do both the comparison arm, which I think is a valuable scientific addition to the literature, and it gives us the chance to get the scans. Yeah.
I have a question though for the computational.
Yes.
You said we do it because we can't wait for 2 years. What is the correlation between the computational parameter estimate and the 2 years?
No one knows yet. That's what I'm asking CIHR to give me money to figure out. But this is exactly why. Yes. Yeah. Yeah. So we don't have any cohorts that have been phenotyped for long enough to know. And we've submitted, I think, we've submitted grants to Wellcome Trust, to Europe Synergy, to NIH, fingers crossed they still exist, and to CIHR with the same essential question of, if we phenotype these people long term, what can we figure out in terms of outcomes? We're very hopeful about this because the signals are quite strong and consistent across studies, which is nice. Like, we do this in different populations in different labs. I'm a different lab than the Yale lab, right? Like, even though he's my mentor, like, it's a different population, all these things. And the signal is still there. So it's a consistent, reliable, reproducible effect. And not just for our task, but for other people's tasks as well, for their effects that they find. And it's very exciting. And I just hope somebody gives us the money to do the study. But we don't know yet, is the answer. Yeah. Obviously, we think it will, but we don't know. Because if we could show that, then we have a mechanistic, like, we can say the information processing change that happens close into psychosis development is X. We can actually give a mechanistic story that is consistent and verifiable, which would be very exciting, but someone has to give us the money to do it. Yeah. More Albin. Can never get enough Albin.
Thank you. So a bit about this, the New Yorker study. How many workers do you expect? I think this is like the main problem that they're like, I've heard it in the walkways of stairs. You know, it's the last clinical high risk trial, basically. Like, if you find a negative finding there, then it's not usually a thing. The healthcare managers do open up, but people say, like, well, it's too bad about it, but it's getting to these early access clinics. So you're going to get very few relatively soon.
Yes.
Psychosis converted.
Yeah.
Do you expect to see these size people? Do you expect to have enough together with the staging? Like, you will do the staging and have your psychosis do you have our idea?
So I was not part of ProNET. I was too young, unfortunately. I was born at the wrong time. I came in just as they were sort of like wrapping up. It depends entirely on how assiduous the sites were in their recruitment. And it's true that we do have okay, the people who come to high risk, this is a bit of a clinical aside for a second. The people who come to high risk clinics often, I think, are the patients who have the weirdest cluster of symptoms, not for psychosis specifically, but just in general. And they don't really fit at many existing clinics, and they'd be people who would otherwise languish without treatment. And so we do have kind of a moral kick in the pants to try and mold things, let them get into our clinics. Just because they're in our clinics does not mean they would necessarily be recruited into ProNET. So ProNET does have certain criteria that have to be followed. This gets to the heart of whether or not I think the CHRP criteria are good criteria to go by. The answer to that question is no. I don't actually believe the CHRP criteria are sufficient. I believe they are an important part of the whole, but I don't think they're enough. And we know this because other longitudinal studies, but they were retrospective, which is the problem of prodrome, are very clear in the sense that the attenuated psychotic symptoms happen later. So we're losing the people who had what's it called? Other symptoms then developed, and we're losing the people who never developed the attenuated psychotic symptoms, the people who never come to the clinic. And I expect a signal maybe of around 10 to 20%, which is what we've been seeing, right? So 100 people, which is still something we can do something with, right? But even 60 to 100 would be good. I know that it happened. I had one patient myself who was in ProNET who converted while he was my patient. And it was a clear, like, beautiful, classic textbook conversion. So it does apply to some people. My concern is that the people that applies to is not equivalent to everybody who develops schizophrenia, right? My hope is that this study gives enough of a positive signal that people will say, this is worth pursuing, but it's not sufficient, which will then open the door to the NIH study that I submitted with Al Powers and also Scott Woods, who's the guy who ran ProNET, where we'd be looking at a much larger population basis and computationally phenotyping people online. And then, you know, we can follow people, and then we can potentially, once people get to a point where we're worried about them, call them in for all the fancy stuff, right? So, but there are ways of doing this at a much larger population-based, focus that would help us, I think, capture more people. It would still have it would probably have a lower conversion rate because you're looking at more people, but you'd have a larger proportion of all the people who are going to convert. And I think that's what we really care about. Given a population, have you captured everybody who converts in a given time period? Which I think is a more important metric than of the population you picked, how many people are going to convert. Because I don't think we know enough to actually do our screening yet. That's the issue. So I think first we need to capture most people in a population that convert, phenotype those people, and then use that to develop cohorts in the future. Which sounds like a one step forward, it's 2 steps forward, 1 step back kind of thing. But I think it's just the iteration that we need to be tolerant of in scientific endeavors, especially in this one where things are so difficult to define. That was a bit rambly, I apologize. My pleasure, thank you.